Okay, so we'll go ahead and move on to our last session today. I'd like to introduce Carina Arovec. She received her BSN from the University of Utah here in Salt Lake City and completed a master's in nursing and postmaster's nurse practitioner program at the University of Washington in Seattle. She is currently a nurse practitioner with the Fred Hutchinson Cancer Center in Seattle. Carina has worked in the hematopoietic stem cell transplantation area for 29 years as a clinical nurse specialist, as a floor nurse, as a charge nurse, and then for the past 17 years as a nurse practitioner. Her focus for the past 15 plus years has been in long-term follow-up, where she assists with the management of over 5,000 patients who are beyond 100 days post-transplant. Please join me in welcoming Carina.
Good. Well, I want to thank all the organizers for inviting me to speak about my very favorite topic, which is late complications after transplant. And I think I just... this is the Hutchinson Center and the Seattle Cancer Care Alliance, where we see patients. And I swear that Mount Rainier has been photoshopped in. It never quite looks like that when you're in Seattle. I know it's there. Just don't see it very often. So why is this such an important topic? For one thing, the survival rates have really increased over the last 30 years. In 1970, only about 30% of patients survived more than 100 days. In 2005, over 80% of patients were surviving over 100 days. And now, among patients who are 2 years post-transplant and free of disease, the survival can be expected to be 80% by 15 years post-transplant. And among those that are 5 years post-transplant, free of disease, it's 80% at 20 years. So our growth is our patient growth has been incredible. We have over 5,000 patients. But what happens when they live longer is now we're seeing more chronic GVHD. So what is chronic GVHD? It's the most common late complication after allogeneic hematopoietic transplant. The median onset is about 6 months. So obviously it can occur earlier, and many times it does. And it can occur later, and some patients, a few patients, can even be diagnosed with their first diagnosis of chronic GVHD beyond 1 year post-transplant. But usually, if you haven't seen any chronic GVHD by 2.5, 3 years, it's probably not going to happen. It affects multiple organs with inflammatory and fibrotic type clinical phenotypes. And why is chronic GVHD such a problem? It occurs in 20 to 70% of patients surviving more than 100 days, depending on which study you read. And for our patient population, it's about a 60% incidence. It's a major cause of death, despite lower relapse rate, and 40% survival at 8 years. So there is a significant impact in their life. And certainly there's an impact in the quality of their life. The more treatments that we give them, more medications that we give them to treat their chronic GVHD, the lower their quality of life. And it's also associated with more secondary malignancies. So how do I approach, and this is how I want to approach this talk, how do I approach a patient beyond day 100 that I'm asked to see? First, I look at their GVHD. Do they have acute GVHD? Do they have classic chronic GVHD? Do they have the overlap GVHD, acute and chronic GVHD? And this is important because it gives me some idea of how to treat the patient and how long I can expect to treat the patient. But I also look at their disease status. Do they still have minimal residual disease? I look at their infection history. Are they still being treated for active fungal pneumonia? Do they have a lot of CMV reactivation? So that it helps me make decisions about how aggressively to treat the steroid dose, et cetera. And I also look at other complications. Do they already have avascular necrosis? Do they have osteoporotic fractures? Can they not tolerate high-dose steroids because they become psychotic on steroids? So I know that you guys have seen this over the days of the conference, but remember that acute GVHD and chronic GVHD are no longer distinguished by time post-transplant, although acute tends to occur early, but it's really just a red rash, hepatitis, liver function test abnormalities, and gut GVHD, whereas chronic GVHD is diagnosed by its different manifestations, which obviously can also occur in the skin. but don't present necessarily with a red rash, can present with lichen planus, hyperpigmentation, hypopigmentation, morphia, sclerotic manifestations, hair loss, premature graying, oral sicca, oral ulcers. It can cause wasting syndrome. They lose weight. And one of the other things with chronic GVHD is that it impacts the immunity. So there's more infections in patients who have chronic GVHD, regardless of whether they're being treated with a lot of immune suppression or not. So what kind of sites are affected with chronic GVHD? So the gray is the patients who've gotten marrow as their stem cell source. The blue is patients who've gotten blood as their stem cell source. Regardless of the source, the most common sites are the skin and the mouth, followed somewhat evenly by eyes, GI tract, and liver, which these two would give you the overlap syndrome if they also have gut and liver GVHD. But we also see it in the joints, in the muscles, the vagina, esophagus, fingernails, toenails, lungs, and serosa. This would be things like pleural effusions, pericardial effusions. So when I walk in to see a patient, what do I ask them and what do I look for? So I ask them certain things every single time. Does their skin feel tight? Does it burn? Does it hurt? Do they sweat? Some patients with chronic GVHD don't sweat, and it can lead to problems with them overheating when they exercise. Have they lost scalp or body hair? Do they have premature graying? Has their hair always been that gray, or is this new with the chronic GVHD? Are their nails breaking? Do their eyes feel dry or irritated? Is it hard for them to sit in a car with the heat on because it's just irritating their eyes? Is their mouth sensitive all of a sudden to things like pizza that they used to be able to eat before? All of a sudden, can they not eat chips or other things that are rough? And have their tastes changed again now that they're further out from transplant? I ask them about food or pill sticking. I always ask them if they can swallow the big pills like the Bactrim. And you do need to make a distinction between dry mouth and dry esophagus or dry posterior oral pharynx that's contributing to problems with them swallowing. But some patients do develop strictures in their esophagus, and you can tell those patients that either stop taking their pills or they stop eating certain foods because they're having trouble swallowing. I ask them if they have a cough, if all of a sudden their exercise tolerance has decreased, about GI symptoms, all the typical nausea, vomiting, diarrhea. But I also ask them if they started losing weight. And a lot of patients want to lose weight, and they say, oh, yeah, all of a sudden now the weight that I want to lose. Well, you don't want them to have unintentional weight loss. I ask them about joint stiffness or pain, and then for the women, vaginal dryness or pain with intercourse. And for the men, I ask them if they have any rashes on their penis or if there's any pain or dysuria. So when I examine them, I always do it in the same order. I look at their mouth. I look at the buccal mucosa. I look at the hard and the soft palate. I look at their lips. I look at the gingiva. I look at their tongue. So this is a patient with lichenoid changes in erythema in their hard palate. And you can see their lips, this patient's lips. He has an ulcer here. They're very dry. They're very irritated. These are mucoceles. Patients will often complain of little blisters in the back of their throat with certain foods. They come and go. They tend not to be tender, and many patients don't even know that they have them. These are lacy lichenoid changes that we see with oral GVHD. This patient is developing a pseudomembranous ulcer, and there's some erythema around here. And again, this patient is developing a pseudomembranous ulcer in here and with erythema. Next, I look at their eyes to see if they're injected, dry. Some patients walk in, they can't even keep their eyes open, or they're wearing 2 pairs of sunglasses because the light in the room bothers them. So this patient has very injected and irritated eyes. I look at their skin. I examine and touch their entire body. I ask them to disrobe and put on a gown because it's very easy to miss things if all they're doing is pulling up their sleeves or pulling up their pants. So I look for color and lichenoid changes. Have they lost pigment? Have they gained pigment? Is there any erythema? Do they have lichenoid, those shiny lichenoid changes? And I touch and pinch areas, starting with the face and work down to their feet to see if they have any thickness, whether there's thickness that's movable, whether it's really thick but I can still pinch it, and whether it's not even pinchable, hidebound type changes. So, for example, this patient, it kind of depends on what their normal skin thickness is, but it looks slightly thick. They have some lichenoid changes. They have pigment changes, patchy hyperpigmentation. They may have lost pigment here. It looks quite light. They have some erythema here. Whereas this patient This person is trying to pinch their skin, and it's slightly pinchable, but not very. It's tight. And this one can't pinch whatsoever. And this patient has erythema. He has a ridge there and here from chronic GVHD from the sclerosis, and some dimpling in there. This is what we want to avoid. This patient has lost hair. You can see that he has what we call poikiloderma, the dark, the light, and the red. He's got red patches. He's got contractures in his wrists and his elbows. This patient has shallow ulcers and also some poikiloderma. You can see all this erythema on the fingers. And this person also has ulcers that look like they're starting to get infected. So the cumulative incidence, it's very important to recognize this, to be able to treat it early before it gets to that point. The cumulative incidence of sclerotic GVHD in patients who have chronic GVHD is about 19%, almost 20% by 3 years post-transplant. It's something that tends not to occur early, but tends to occur somewhat a little bit later. So one of the things that we use to help us guide our therapy and see if patients have responded is almost every time. Now, we're a referral center, so we don't see patients every week necessarily. We usually see them, depending on how bad their GVHD is, we might see them once a month, every 3 months, every 6 months, sometimes once a year. Every time they come for an evaluation, especially if they have any skin changes, we'll photograph their skin and range of motion. And there's very specific photographs that they take. We have these all on a website. We must have millions of photographs on patients. But they're very helpful for determining response. We also do, if they have sclerosis, we'll do a modified Rodnan skin score, which is a pinch test. It's very subjective, but usually if the same person does the test every single time, then you can tell the difference whether the patient has improved or worsened. And it's measured at 17 different sites. The score is 0 for normal, 3 for not pinchable. And then you total up the total score, and we document that and then compare it from time to time each time that we see them. Some centers use the Vienna Total Skin Score, and we use also the NIH skin scoring system. We also record the percentage of skin involved with GVHD. This helps you to determine whether this patient has progressed. Now their sclerosis, instead of covering 10%, covers 40% of their body surface area. And then one of the other things that we do, of course, is the range of motion, looking at all their major joints. So we look at their elbow extension, shoulder flexion, their wrist extension, and their ankle dorsiflexion. And I also have patients squat, which helps me to see what their strength is. It helps me to see if they can bend their ankles, their knees, and their hips. So this is a patient who has contractures in his elbows. That is the most that he can straighten his elbow. You can see he has dimpling in here, some deep cutaneous sclerosis in there. This patient, that is the most that he can flex his wrist. Instead of being able to go like this with the prayer position, all he can do is he can't bend his wrists. And he can't make a tight fist. That's the other thing I ask him to do to see how well their fingers work. And I often ask patients, can you unscrew a jar? Can you open doorknobs, doors that have knobs on them? Because it's very hard if you can't make a fist. This patient has very tight ankles from the sclerosis, and that's as much as he can bend his ankles and his knees. So this is also a very helpful tool, is using this, which we have in many of we can use when we see a patient, is just to circle what their range of motion is. It makes it very easy to compare from one time to the next, whether they can only go up this far, or they can only they can't straighten their elbow all their way, or what their wrist extension is. So no talk about chronic GVHD is complete without talking about pulmonary GVHD. There's two major types. There's bronchiolitis obliterans syndrome, and there's cryptogenic organizing pneumonia, or what we used to call BOOP. So bronchiolitis obliterans syndrome is the more severe and pretty much more devastating of the two. It occurs in 2 to 14% of allogeneic survivors, depending on which study you read, manifested usually by dyspnea, cough, reduced exercise tolerance. In some patients, it can come on suddenly. In some patients, it can come on after a respiratory infection. In other patients, after just gradually over time. We're very liberal in how we do and how often we do pulmonary function tests. Usually, almost every time that we see a patient, like I said, we see them maybe every 3 months, every 6 months, sometimes monthly, we'll do pulmonary function tests, or at least spirometry to monitor, because this is the only good way of monitoring of screening for pulmonary GVHD. So we'll see obstructive changes on pulmonary function tests, which lead us to do a high-resolution CT scan of the chest, and we'll see air trapping on the high-res CT. Unfortunately, it responds poorly, and there's a high mortality. They tend to die of lung infections. But it is not a death sentence. I have many patients who are alive many years after their diagnosis with bronchiolitis obliterans who've gotten off their immune suppression. They still have crummy pulmonary function tests. They can't run. They walk slowly, but they do the things that they like to do. They're with their family. They're with their friends. Bronchiolitis obliterans is almost always treated with 1 per kilo of steroids and with the FAM protocol, which is inhaled fluticasone, azithromycin, and montelukast or Singulair, usually with a calcineurin inhibitor or with some other immunosuppressant to use as a steroid-sparing agent. Initially, we'll do monthly PFTs, usually for at least the first 3 months, just to make sure that we've stop the progression of their bronchiolitis obliterans and to see if they're responding. And then every 3 to 6 months, depending on their response and how severe it is. And then I'll usually do monthly spirometries while we're tapering the steroids. So this is an example of somebody's pulmonary function test who has bronchiolitis obliterans. You can see the FEV1 is only 48% of predicted. The FEV1 over FVC ratio is low, 36%. Total lung capacity is normal. The residual volume is high, 145%, and this is what the CT scan looks like. It just has air trapping, a little bit more dark here than you would expect, but no infiltrates. In contrast, cryptogenic organizing pneumonia, or COP, or BOOP, presents like a pneumonia. Patients present with a cough. They look like a pneumonia. If you do pulmonary function tests, they show restrictive changes, usually a low diffusion capacity, and you're always going to do a chest x-ray at least on somebody like this, and on chest x-ray and CT scan, they'll have patchy consolidation. They almost always need a bronchoalveolar lavage because they look like they're infected to rule out infection. And ideally, the diagnosis is based on a lung biopsy. But many patients, we don't do a lung biopsy because there's so many problems associated with doing a lung biopsy. So we do treat some patients empirically based on the fact that their bronch is negative and that they have restrictive changes and they have other sites of GVHD often. Most patients respond to steroids. It's also 1 per kilo of steroids. And they tend to get better. Sometimes they don't go back to normal pulmonary function tests, but they do improve. So we treat with prednisone 1 per kilo. And most recently, we've been adding clarithromycin or azithromycin based on a study that was published in Chest about 6 or 7 years ago that showed that clarithromycin had a steroid-sparing effect on patients with cryptogenic organizing pneumonia. We treat them for a full month with 1 per kilo daily and then gradually taper them off over about 6 months. We do monthly PFTs initially, maybe 1 or 2 initially, just to make sure that they're responding, and then I'll do either spirometry or some pulmonary function tests every 1 to 3 months during the taper, just to make sure that they're not flaring again. Some of these patients will go on to develop obstructive changes, bronchiolitis obliterans, so you still have to monitor them. So this would be an example of pulmonary function test in somebody with COP or BOOP. So the FEV1 is low, 42%, but the FEV1 over FVC ratio is normal. It's over 70%. Total lung capacity is low, the residual volume is low, and diffusion capacity is low. And this is what a chest CT scan would look. You'd want to do a bronch on this patient. So once I've looked at this patient, we score every patient that we see for chronic GVHD based on the NIH guidelines for chronic GVHD. And this form covers the skin, the mouth, the eyes, the gut, etc. And it goes from 0 to 3, 0 being usually no signs or manifestations of whatever site that we're looking at, the skin or the mouth, the eyes, etc. Whereas 3 would be severe. For example, in the skin, it's more than 50% body surface area involvement, or if they have deep hidebound sclerotic type features. So once we've diagnosed the patient with chronic GVHD, how do I treat this? And I want to go through, unfortunately, there's no good guidelines because there are no good studies, comparative studies, to say this treatment is better for patients with chronic GVHD. So the standard of treatment, so ideally we would enroll a patient in a study so we can learn more. But if there are no studies available or the patient isn't eligible, the standard of treatment for chronic GVHD is 1 per kilo of steroids plus or minus a calcineurin inhibitor. Now, we don't always add 1 per kilo. For example, if the rash is limited or they just have some patchy lichenoid changes and nothing else, then we might use PUVA or UVB. If they just came off their prophylaxis for their immune suppression, we might resume it if the GVHD is very limited. and mild. We'll, of course, add artificial tears, etc. If they have dry eyes, we'll resume ursodiol if the liver function tests are starting to get elevated. But if they need steroids, if they have extensive GVHD, either moderate to severe chronic GVHD, they need 1 per kilo steroids plus some other steroid-sparing agent. We usually treat them for 2 weeks with 1 per kilo daily. And then at our center, we taper them to 1 per kilo every other day over about 4 to 5 weeks, leave them there for about 3 months, and then taper them again to 0.5 per kilo every other day, and then watch them and see how they do and whether we can continue to taper, just depending on how they're responding, and try to get them off their steroids. So some caveats about treating chronic GVHD. There is no benefit whatsoever with undertreating or overtreating chronic GVHD. I'm sure that you, and certainly I, have been tempted. I look at a patient who's off their immune suppression, and I have to tell them they're going on 70 milligrams of steroids and back on their calcineurin inhibitor, and they just are devastated. So it's very tempting to say, oh, okay, I'll treat you with 30 milligrams instead. Almost invariably, every single time I've done that, they don't respond, they progress, and you have to go up to 1 or 2 per kilo to get them under control. So I try to avoid that temptation, and I try to treat them adequately. There's also no benefit to overtreating. For example, continuing their prophylaxis over time, because that increases their risk for relapse. So, and remember that chronic GVHD is a chronic disorder. We'll talk about the length of treatment in a little bit. And control of chronic GVHD is not the same as the patient achieving tolerance. So you can control the GVHD, you have good control, you taper their steroids, they're still okay. You have to be very careful about tapering them off their last drug because they can flare, and many times they will flare. And remember, with a patient with chronic GVHD, when they progress, they could have just had skin and oral GVHD, and when they progress, they could develop lung GVHD, they could develop sclerosis. So you really want to avoid this yo-yo effect of tapering them too fast, they flare, you have to put them back on immune suppression, you end up giving them more steroids this way. On the other hand, we do want to taper them to the lowest steroid or in total systemic immune suppression dose that controls GVHD, which unfortunately is by trial and error. If this patient has had a good response, very gradually you taper the steroids, wait a while, you can very gradually taper their other immune suppression, and then most patients, if you're still early after the treatment, 1 or 2 years, will probably progress sometime, and then you bump them back up and leave them there for a while. Patience is the key. So what happens to these patients? At 3 years after their primary treatment for chronic GVHD, remember this is not after transplant, this is after their primary treatment for chronic GVHD, which may be 3.5 years, 4 years after transplant, about a quarter of the patients are off all their immune suppression. Some, a little bit over 10%, are still on their first therapy. This was from a study in 2003, or for review in 2003. About a third of the patients had started on second-line therapy, which means that they had failed their primary therapy and put on second-line therapy. Now that number is closer to 50 or 60%. And some patients relapse, some patients have died from non-relapse mortality. So what do you do when patients fail their first therapy, and how do you know that they failed their first therapy? So the definition of failure could be 3 things. They progress despite 1 per kilo for 2 weeks. Their rash gets worse, their mouth gets worse, everything gets worse. You know you've got to do more. Either add more steroids or add more treatment, change your treatment therapy. Also, then we watch them. If they've responded at the 2 weeks, we start to taper them to 1 per kilo every other day. If after, kind of depends on how severe their GVHD, if it's fairly moderate, we wait 3 months. And if they really haven't gotten any better after 3 months and they still have active GVHD, you need to change something. If somebody has really severe GVHD and nothing has changed by 1 month, we may change their therapy. And also the inability to taper steroids by below 1 per kilo per day after 2 months of adequate therapy is considered treatment failure. So what do you do if patients fail their first-line therapy? Unfortunately, there is no consensus what to do if they failed their first-line therapy. It's preferable always to enroll a patient in a study for secondary treatment if one is available. But what if a study is not available? So I want to go through how I make decisions with either alone or with my attending when a patient has failed their initial therapy. So I base my decisions based on published studies, We've all read there's many published studies about individual treatments for steroid refractory or steroid dependent chronic GVHD. I also look at how they present. Do they present with sclerosis, with lung GVHD? Do they just have really bad oral GVHD? I look at how they present with their GVHD. And experience, because my experience is definitely not the same as the published studies. So some published study, almost all of them say 30 to 50% response rate. Some say 70%. And experience tells me that's not always true. I also look at cost. Some patients have very poor insurance, and the difference in cost between something like prednisone versus rituximab is huge if somebody has to pay for this out of pocket. And I look at toxicity associated with each treatment. What if they already have renal insufficiency? Maybe you want to change from their calcineurin inhibitor to something else. If they have hyperlipidemia, you may want to rethink about adding sirolimus. If they have neuropathy, you may want to rethink their calcineurin inhibitor. And I look at other concurrent problems, such as do they still have minimal residual disease? Do I really want to add 2, 3 drugs to their regimen? Probably not. If they have avascular necrosis, I may temper the dose of steroids. Or if they have active fungal pneumonia, I may want to temper their dose of steroids. So what do I do when I look at this patient and I see that they have chronic GVHD? So if the patient has sclerosis, almost always they need prednisone, at least for a certain period of time. If they have a lot of other problems, we might taper their steroids fairly rapidly, but almost always steroids. Photopheresis is a good treatment for sclerosis. Again, not every patient responds to photopheresis, but we'll usually try it for at least 6 months. Rituximab has been a good choice, and again, not every patient responds. Imatinib has been shown to reverse some of the sclerosis in some patients. And in a few patients, we've used pulse lidocaine infusions, which has helped to reverse some of the sclerosis in a few patients. Also, for that patient who has pain in their skin from their GVHD, this also helps to relieve the pain. One of the things is that PUVA and UVB is not effective for sclerotic-type manifestations of GVHD. If they have fasciitis and joint contractures, again, these patients always need steroids. Many patients respond well to rituximab or photopheresis, and if it's fairly limited, we'll use low-dose weekly methotrexate. If they present with arthralgias and mild and limited contractures, like let's say it's just their wrist, we'll use low-dose weekly methotrexate and about 20 milligrams of steroids. So this is a patient who got rituximab for his fasciitis and joint contractures. So this is day 80. You can see he still has his Hickman catheter, and this is the beauty of having these photographs. You can really compare over time. So his wrist extension is normal, his shoulder flexion is normal, and then he tapered off his immune suppression. This is how he came back to us. This is the best he could do with his wrist extension, and this is the best he could do with his shoulder flexion. He got, over about 2 years' time, he got 12 doses of rituximab. So four doses, one every week, and then a few months later, 4 doses once a week, and then about a year later, 4 doses once a week. And this is how he responded, almost back to normal and almost back to normal. And his sclerosis resolved. So what about the patient with severe IGVHD? In addition, not everybody, if they only have IGVHD, and one of the other speakers alluded to this, that some manifestations of GVHD are sequela of GVHD and some are active GVHD. It's very hard to tell about their eyes. Now, if they're flaring with other sites, of course, you need to use systemic immune suppression. But if later on the big thing is eyes and other sites of GVHD are stable, you don't necessarily need to add more systemic immune suppression, but certainly artificial tears, lubricant ointment, send them to the ophthalmologist to plug their tear ducts. They can get Restasis with the cyclosporin eye drops. I send patients to the Harley store to get occlusive eyeglasses because they have goggles that look very nice. They aren't quite as yucky as goggles, but basically occlusive eyeglasses are like goggles. They put them on, they fit against their face, and they prevent the tears from evaporating. One of our ophthalmologists makes these autologous serum eye drops. I send the patient to the lab. They draw 10 cc red tops of blood, spin it down to 1 10 cc red top, and then they take it to the ophthalmologist who puts it into all these little tiny sterile vials of eye drop vials. They freeze them, take one out at a time, and they're very, very soothing. One of our ophthalmologists places bandaged contact lenses for patients who are really having a hard time. They can't open their eyes. They can't walk outside because their eyes hurt so bad. She changes them every week to 4 weeks. They are associated with infections, but they all get antibiotic eye drops. And then some patients will send either to Boston or California for the Boston scleral lens. If they have really bad oral GVHD, in addition to their systemic immune suppression, we'll use topical steroid rinses, clobetasol gel for their ulcers. And if they don't respond to either of those, we'll use topical azathioprine rinses. And sirolimus has been a good drug. Systemic sirolimus has been a good drug for oral GVHD. I won't go into the treatment of gut GVHD because I think you probably are all aware of gut GVHD. You need to rule out infections, and you almost always need 1 per kilo. But just to say is that some patients are still on mycophenolate and complaining of weight loss, diarrhea, decreased appetite, etc. And mycophenolate and even Myfortic has adverse effects on the gut. And if we don't think that the Myfortic was useful for their GVHD, we'll take them off Myfortic. Now, I'm often talking about these patients might be 2 or 3 years post-transplant and still on Myfortic for their treatment of their GVHD. And if they're having a lot of problems, I will first think about stopping their Myfortic and maybe substituting something else, but also at the same time we'll send them to the gastroenterologist, etc. So for severe liver GVHD that is not responding to standard therapy, even if they have therapeutic levels of their oral systemic immune suppression, we'll often put them in the hospital for IV tacrolimus. Even if they have therapeutic levels, there's something about that, must be that first pass through the liver. We've rescued patients who have horrible liver GVHD with giving them IV tacrolimus plus their steroids. So what about other treatments? So the people at Dana-Farber about a year ago published a study on low-dose subcutaneous interleukin-2 infections. We've treated 4 patients with just severe multi-system chronic GVHD that have failed not only first-line, second-line, third-line, fourth-line therapy. And we've gotten responses on a couple of them, and one of them is too early to tell. And another treatment that we've used is total lymphoid irradiation, as described by the French. We've used this in a couple of patients. We've had marginal success. For lung GVHD, like I mentioned before, you have to rule out infections, and almost always the treatment is 1 per kilo of steroids. Photopheresis has been shown to be a steroid-sparing agent for lung GVHD, and we'll use the inhaled steroids in the FAM protocol, remember, the fluticasone, azithromycin, and montelukast. And I have rescued, everybody laughs at me and they tell me that my favorite drug is azathioprine at work, because I have rescued many patients who have failed first, second, third, fourth line therapy with azathioprine plus their steroids. So what about other drugs? So a few years ago, Dr. Paul Martin published a study where he added mycophenolate to standard treatment for initial treatment of chronic GVHD. Unfortunately, there was no improvement. There was no benefit in achieving tolerance. We couldn't get people off their immune suppression any sooner than we could just with standard therapy. There was no steroid-sparing effect, but there was a trend toward increasing risk of recurrent malignancy. So it really fell out of favor for us. And now we're starting slowly with a few patients treating them with mycophenolate if that seems the appropriate drug to treat. We'll use thalidomide in a few select patients. It's quite effective for skin, or can be quite effective for skin and oral GVHD. It's just hard for many patients to tolerate. We'll use ATG in patients who really have horrible rip-roaring, usually both acute and chronic GVHD, the overlap syndrome, but there is an increased mortality rate from infections. And we have used cyclophosphamide for treatment of chronic GVHD for patients who have failed, again, first, second, third, fourth line therapy, but they all get infected. And these other drugs that other people may be familiar with, we just don't use because we aren't familiar with them or we're concerned about the toxicity. So how long does chronic GVHD last? So we looked at 750 patients of our transplant patients. The median time for patients, so 50% of patients were off immune suppression, 50% of patients were still on immune suppression. If they got marrow as their stem cell source, almost 2 years post-transplant, it was only 50-50. If they got blood as their stem cell source, it was 3.5 years for half the people to be off and half the people were still on. And this data goes out further. At 7 years, patients who were free of disease, 15% of patients still were on immune suppression for chronic GVHD at 7 years post-transplant. So it can last a long time. Now, usually those patients are not on 1 per kilo of steroids. They may be on 10 milligrams every other day in a very low dose with subtherapeutic levels of tacrolimus. But there's a substantial number of patients who are still on immune suppression. So what other things do we need to think about when we treat these people long-term for chronic GVHD? You need to prevent infections. That's the major cause of death from chronic GVHD is infections. We use acyclovir for herpes and VZV prophylaxis throughout the time that they're on immune suppression and often for 6 to 12 months afterwards, even after they come off, because about 30% of patients, when we think that they're perfectly ready to come off all their immune suppression, everything's going well, about 30% of people will flare again, need to be put back on immune suppression. And because many of our patients, we do telephone triage with them because they're scattered all over the country and really all over the world, and we get these phone calls that their GVHD has come back. Often people forget to put them back on their acyclovir and their other prophylaxis. So we also prophylax against pneumocystis and encapsulated bacteria infections. We prefer to use daily Bactrim, but if they can't use daily Bactrim because of counts or allergies, whatever, we'll use Dapsone plus penicillin. There's some other, we use other drugs too if they can't tolerate Dapsone or if they get hemolysis from Dapsone or if they're allergic to penicillin. We'll use fungal prophylaxis if they're on more than 1 per kilo of steroids per day for more than just those 2 weeks. We don't add it for those first 2 weeks that we use to treat chronic GVHD. But we would for somebody who has like BOOP or COP that we're going to treat for a prolonged period of time with 1 per kilo. We have a very low threshold for clinical evaluation, doing bronchs, blood cultures, et cetera. And we start vaccinating them at 1 year post-transplant, unless they have horrible rip-roaring GVHD at that time. We'll start vaccinating following the CDC recommendations, and our guidelines are on our website. The other issue that I deal with is secondary malignancies. So early after transplant is not quite as common, but as you can see from this graph, the risk for secondary malignancies increases with time post-transplant. So when I'm seeing a patient that's 10 years or 15 years post-transplant, I'm adamant about them being screened for secondary malignancies. The risk is about 1.5 to 3 times the general population risk. For solid tumors, we say it's about 2% at 10 years and almost 7% at 15 years. The most common sites, barring all this stuff, that I tell patients and that we've seen is skin. The skin usually is squamous cell or basal cell carcinomas, very rarely melanoma. So skin, mouth, their neck, and head. So what do we tell patients as far as screening? I tell them they should have a complete skin exam at least annually. They really should do this with a dermatologist that looks at them from head to toe, not just somebody who lifts up their shirt and says, oh yeah, you don't have any moles. I have had many patients diagnosed with skin cancers. We have them go to a dentist every 6 months. Early on, it's unusual to have oral cancers, but when the patient is 15 years post-transplant and they still have lichenoid changes, I tell them you have to see your dentist every 6 months. And if that dentist ever tells you that they want to do a biopsy, you say, when do I sign up? Because oral cancers can be quite devastating. We have women get their initial mammogram sometime between 30 and 40 years of age, and then annually there is an increased risk of breast cancer, especially if they've gotten radiation in women. We have them do the breast self-exam, annual pap smear, and they should be checked for high-risk HPV. For men, we have them do the digital prostate exam when they turn 50, annual stool guaiacs at age 45 and beyond. And I can't tell you the number of people who have not had a screening colonoscopy at age 50, and we encourage them to do this, and then the follow-up would be depending on what the gastroenterologist finds. We counsel them against tobacco. There are patients who are still smoking. Against sun exposure. That is the biggest thing one of the things that I counsel people is they have to avoid the sun. Even in Seattle, they have to wear sunscreen every day because they do get exposed to rays. And if they're going on vacation to Mexico or to Florida or to Hawaii, that they have to be very careful about avoiding midday sun. So you can read this yourself, but we can ask patients to move to Seattle instead. It really isn't always cloudy there. So the other issue that I deal with is bone complications, either osteoporosis or avascular necrosis. So what are the big things? We want to minimize the steroid use as much as we can. We know that the more steroids they get, the more risk they have of both osteoporosis and avascular necrosis. We ask them to get enough calcium, both between diet and supplements. Some people take this as being all supplements and they're still drinking milk and et cetera. But I tell them that that's between diet and supplements. Vitamin D, although I also check their vitamin D levels to make sure that this is sufficient. We tell them to get weight-bearing exercise every day to build up their bone density and keep up their muscle strength. If they're on steroids, if they're elderly, if the initial DEXA was abnormal, we get DEXA scans every year. If it's indicated, we'll encourage them to use hormone replacement if they're of the right age group, et cetera. And we'll use bisphosphonates in patients that are on long-term steroids. Now, with all the data about bisphosphonates causing abnormal femur fractures, et cetera, we've kind of toned that back a little bit. But I started this before the era of bisphosphonates, and I cannot tell you how many patients had horrible compression fractures. So you just have to use it with a little judgment. So there's all these problems that these patients can be exposed to or have problems with for many years after transplant. One of the things that we do is that every year we send out a questionnaire to every one of our patients annually around their anniversary date. And it's a very lengthy questionnaire, but one page is dedicated to any of their comments that they want to make, anything that they want to say. And then once a year, Dr. Martin and some of the other LTFU staff review all the comments from the patients that have written back that year and provide us an anthology of their comments. So not all of them, they just select a few. So I went through them for this last year. So this is a patient who's now 8 years after transplant. He's now 70. And I'll let you read this. I don't think I need to read this. But the thing that we need to remember is that all these patients had lethal diseases. And no matter what, they've had acute GVHD, they've had chronic GVHD. Some of these patients are living for many, many years free of disease. They're enjoying their families. Some of them have children. They have grandkids. They see their kids grow up. They're all very happy. I have had one patient, I've done this for 29 years, I've had one patient that whole time tell me that she wished that she hadn't had a transplant. Every other patient has been, no matter what they've gone through, hospitalizations, trachs, being in the ICU, they've all said they were happy that they did this. This is a patient who's had 2 transplants. Her first transplant was 26 years ago. She did well. She had a lot of problems, with this transplant. Then she did okay. She got pregnant. While she was pregnant, she relapsed. She delivered. She got chemotherapy. She came for a second transplant from the same sister, and now she's 16 years after her second transplant. She's off all immune suppression. She had a lot of GVHD. She's off all immune suppression. She just had her 50th birthday party that she invited me to. Any questions from anybody? Yes? That is a problem. So my boss is somehow better at it than I am. And sometimes I've been very lucky. I've even talked to like the medical director of insurance companies, trying to get them to approve it. If they're on a study, many times the study can provide the drug, which is great. And I've had patients just not be able to get some of the drugs. The thing that helps me is that there's no one good drug for any of this GVHD. So if I can't get the imatinib, I'll try something else. The one thing that has helped is that because Medicare covers photopheresis, I have not had problems for years getting coverage for photopheresis. And usually their copay is very little. I've only had one patient recently that couldn't afford the $100 a month copay. Yeah. Any other questions? Yes. The photopheresis? Usually what we do is we try to taper their steroids first, if we can. And then when it's time to taper the photopheresis, so what we do initially, this is what we do. Everybody is a little bit different. So we do 2 treatments a week, every week. They aren't necessarily consecutive. They can be like on a Monday and a Friday, or they can be back to back if that's better for them. And we do that for 4 weeks in a row. And then automatically, unless they have still rip-roaring GVHD, we'll go to 2 treatments every other week. And I usually leave them there until they reach their 6-month mark. Now, if they really have improved and they're getting sick of coming to us for photopheresis, and they look great, and I've tapered their steroids, of course, I'll back them off. And then the next thing we back them off to is 2 treatments once a month. Sometimes, if we're very worried about a patient, we'll do 2 treatments every 6 weeks after that. But usually once they're down to 2 treatments once a month, and we do that for a few months, we'll stop it. The thing with photopheresis is it usually takes about 6 months to see the optimal response, so you really have to plan on long-term treatment. So when I ask for coverage, for insurance coverage, I'll usually say, I'm going to treat them for a year, so then I don't have to be asked again to write anything for the insurance company. But usually we'll treat for at least 6 months. We have patients we've treated for 2 years even with photopheresis, just because we're able to get them off their steroids, but they have problems with their other immune suppression, and so we try to get them off their immune suppression, and it seems to be the best thing that works for them. Yeah. Yes? It isn't in the data, but the data is very old. This data is like 30 years old or 25 years old. So the data initially was that prednisone alone was no better than prednisone plus a calcineurin inhibitor as far as treating GVHD. The one thing that it did is, as a steroid-sparing agent, they got off the steroids sooner, and there was lower incidence of avascular necrosis. And is that different than it would be using other steroids? No. Mm-mm. No, so it's really just preference, because there are no good guidelines and no good studies comparing each one of those. Yeah. Yes? Can you use the mic if you're way back there? Because I don't think I could hear you. It's not on.
Yeah. What do you recommend to patients with scleroderma who have really bad cramping and their hands or feet?
Oh, that's a very good question. Cramping is very hard to deal with. We actually have a whole sheet about cramping. So I always look at their electrolytes, either potassium, their calcium, their magnesium's okay. Sometimes I'll give them a little extra magnesium if it's like borderline and they aren't having any trouble with gut symptoms for their magnesium. I'll give them a little extra. The thing that really helps patients is staying hydrated. Almost every patient tells me that once they get dehydrated, if they aren't drinking enough water that day, it'll make it worse. And then if that doesn't work, we'll use things like baclofen to help prevent, especially if it wakes them up at night. I'll use baclofen at night to help, and that helps some patients. It is hard to deal with the cramping. Any other questions? Wow, I finished on time. That's unusual.